So it's a real pleasure for us to welcome you for this TNT for Medtronic about the Evolut Pro platform. And it's my real pleasure to introduce my co-chair, Grube, who is going to present the session objectives and the live case information.
Thank you very much. Thank you, Didier. And I would like to start with the potential conflict of interest that you can see here on this slide. The session objectives are summarized on this slide. It is to learn about the contemporary treatment strategies enabling safe and efficient TAVI procedure, to learn pre, peri, and post-procedural strategies, as well as tips and tricks to achieve efficient TAVI program in your institution, and also to learn about usefulness of a novel generation Evolut platform in achieving best procedural outcomes. I would like to continue with the patient that we're going to see and being treated from the Swiss Cardiovascular Center in Bern. Our patient today has had progressive exercise intolerance, shortness of breath with NUHA 3, chest pain on exertion CCS2. It is an 88-year-old male with the 180 centimeters and 75 kilo. The prior clinical history is summarized here: valvular heart disease and coronary artery disease, severe symptomatic aortic stenosis with a mean grading of 32, valve area 0.4 square centimeters, reduced left ventricular ejection fraction with an ejection fraction of 30%, and previous PCI distal LAD in 2001. Complete left bundle branch block, and chronic kidney disease with a GFR of 46 ml per minute. He presented clinically with congestive heart failure due to severe aortic stenosis. He's hemodynamically stable. There's a regular rate and rhythm. Physical examination relevant for pulmonary rales and peripheral edema. Risk factors: hypertension, non-insulin dependent diabetes type 2. Lifestyle: independently active, no smoker, and psychological status: well-oriented, cooperative, and integrated. Those are the laboratory investigations as summarized before. The non-invasive imaging, transthoracic echo, severe aortic stenosis with bicuspid anatomy, moderate calcification of the cusps, mean transvalvular gradient, as stated before, 32 millimeter mercury, mild aortic regurgitation, left ventricular function reduced with an ejection fraction of 30% with no regional wall motion abnormalities, eccentric hypertrophy, and diastolic dysfunction grade 1. Those are the CT angiographic pictures. Aortic root dimensions: ascending aorta 37 millimeters, sinotubular junction 22 millimeters, sinus of Valsalva 39. Distance to the coronary ostia is okay, above 10 millimeter with 13 each. Minimal abscess vessel diameter also in order: 8.7 millimeter on the right and 8.5 millimeter on the left. Annular dimensions: the perimeter 81.6 millimeters, perimeter derived diameter 26, area 516 square millimeters, and area derived diameter 25.6. If we look at the supraannular dimensions, measuring plus 4 millimeters above, minimal intercommissural diameter 27.2 millimeters, perimeter 80.7, perimeter derived diameter 25.7, area 466.6, area derived diameter 24.4, and note this is 4 millimeter above the annulus. The invasive imaging measurements: the mean transvalvular gradient 32, so low gradient, aortic valve area 0.4, severe aortic stenosis, indexed aortic valve area 0.2, square centimeter per square meter, stroke volume index 30 ml per beat per millimeter per square meter, mean pulmonary artery pressure 32 millimeter. Those are the imaging, those are the pictures, the angiograms. This is the aortogram that you can see here. The calcifications, very mild aortic regurgitation, the coronaries on the left and the coronaries on the right. Euroscore 2, 8.7%, logistic Euroscore 15.5%, STS-POM 5.5%. Clinical data and angiographic references, again summarized: 88-year-old male, symptomatic severe bicuspid aortic stenosis with a transvalvular gradient 32 millimeter mercury and an aortic valve area 0.4 following Gorlin. Ejection fraction 30%. Estimated risk score is 5.5 STS-PROM and logistic Euro score 15.5% with a Euro score 2, 8.7%.
Thank you very much, Eberhard. We are perfectly on time, only 1 minute before we go live. So just the time to introduce the panel. We have the pleasure today to have Dan Blackman with us, Eberhard Grube as my co-chair, Flavio Ribicchini, and also Lars Sundergaard. So the team in Bern is ready to transmit. We already know that the patient is in critical condition because you've seen that it's a complex patient. It's a complex bicuspid patient. He has some kind of hemodynamic failure, so we will see how the team deals with that, deals with this extremely complex patient with an unstable condition. So hello.
From our side. Good afternoon from our side. Hello. I think you've already heard about our patient today. Let's move ahead to the key objectives and to our strategy. Can we please see the slides? Okay, next. Okay, so we would like to demonstrate the use of a novel generation Evolut Pro platform in a patient with bicuspid anatomy and severe aortic stenosis. Our procedural strategy is displayed on this slide. The patient is under general anesthesia. We already performed pre-closure of the vascular access site with a ProGlide system. We will perform pre-dilatation on the rapid ventricular pacing. Subsequently, we will deliver the Evolut Pro prosthesis, and we will show hemodynamic and angiographic assessment of device success. Next slide. Okay, so we will use the Evolut Pro system. It has two important features. First, recapturability, and second, repositionability. The Evolut Pro system does feature pericardial skirt that reduces the gaps between the transcatheter aortic valve and the native anatomy in order to reduce paravalvular regurgitation. In contrast to the Evolut R prosthesis, the Evolut Pro system requires a 16 French access. Okay, we can go to the next slide. This slide summarizes our measurements as we have seen this before, as well as the sizing chart. You can well appreciate that our measurements are well in the range of 29 Evolut Pro prosthesis. Maybe we can move ahead to the delivery system now. Okay, so as said, for the Evolut Pro system, we require a 16 French access. This is the NVO Pro delivery system, which has been recently modified. And please take a look at the right side of the slide. You can see the modified tip design, with an internal portion of the catheter tip that is a little bit longer as previously in the Evolut R system, and reaches further into the capsule flare portion of the capsule in order to improve trackability and reduce the likelihood of kinking, as you can appreciate on the left lower corner on this slide. Maybe we can also move very briefly to the model. Okay, so we would like to show you the two different tips exactly. You can see the longer tip that reaches into the flare position of the catheter in order to increase trackability and reduce kinking on the lower side. On the upper portion, you see the previous catheter with the shorter internal portion of the tip. But it's important to note that it is only the internal portion of the catheter tip that has been changed, but not the outer portion of the tip. Okay, with this having said, I think we can move ahead to the case.
So Didier and Eberhard, we will start immediately with the case because we have a hemodynamically unstable situation that evolved during the past 24 hours. The patient presented to us a week ago when the EF was 30%. We may be able to show you quickly an echo, what you see maybe here on the TEE probe, the actual left ventricular ejection fraction that has considerably worsened, and we estimated currently to be about 15%. as a matter of fact, the patient is in cardiogenic shock, and therefore we try now to proceed as quickly as possible with the implantation. Our strategy will be to cannulate the valve. As soon as we have cannulated or passed the valve with the guide wire, we will then try to do a pre-dilatation, a little bit in the hope that relief of the obstruction provides at least temporary during the case some amelioration of the hemodynamic situation. However, in case we do have problems, we also need to be able to escalate to other scenarios. And I think also, as we will discuss, the implantation strategy, obviously with the bicuspid valve, deserves some special attention. But we will try to place the valve as quickly as possible.
Stefan, thank you very much. Obviously, that has changed quite a bit from what we've seen before. 15% probably is realistic. Would you mind, you people work, and we've been discussing this from here, the panel and Didier and myself. I was just wondering, given the circumstances that have changed, would you still maintain the pre-dilatation strategy, or would you just say, we go quickly ahead, implant the valve as quickly as possible, and then see what's going to happen, whether you need to do anything else?
Yes, we can have a discussion on this as we go. To be honest, we also discussed this here. I think there are two ways to look at this. One is that by pre-dilatation, actually we improve the hemodynamic situation such that we have more time with implantation of the valve, particularly in the bicuspid anatomy. Conversely, you can take the other attitude that we go directly with implantation of the valve. But we are open also for your suggestions, and we can see what we do. The first challenge, as you know, with the bicuspid valves, sometimes it's a little bit trickier to pass the valve. The patient is also very tachycardic. That is, the diastolic period is not, or the time where you can actually pass is not as extensive as a normal situation. But now we have passed, we do the usual thing. We exchange the AL1 catheter now against a pigtail catheter.
And
we are listening to you.
Just for the audience, there is something that I really like with your technique. When you need to go fast and you need to make it safe for your patient, you could use this thermostrate slippery wire that is more efficient in crossing the valve. And if it was the right choice for this patient. Another point that we could discuss while you guys are working, pre-dilatation is something that is discussed, debated for bicuspid valves, but you're going to pre-dilate with rapid pacing. Do you think that you could skip the rapid pacing phase given the depressed LV function for this patient?
Absolutely. I think the LV function is so depressed that this is certainly a step we could obviate and not look at. Maybe maybe we just take a quick look at the pressure gradient. If you're already there, we won't spend much time on this, but if you're already there, we look what the gradient is.
Yeah, I mean, just Dan Blackman here, Stefan. I personally would agree with your strategy of pre-dilating. You've got an unstable patient, and I think you need to choose which bits of the procedure you're going to do fast and which bits you still need to take your time and get right. So, you've got to get that balance. And I think the BAV is going to improve the hemodynamic situation with little risk. And in a bicuspid valve, it's going to help you to get a good result. So but you could consider using the true flow balloon, which would help you to avoid pacing.
Yeah, that's
you see the patient is actually in cardiogenic shock. You see a large pressure gradient, but you see the end diastolic pressure is really close high. To 40, close to the diastolic pressure.
See, this is
so
what
we really need to proceed.
Right. I mean, you do this, Stefan. Do you take care of your patient? And we are discussing this here on the panel. Obviously, wish you all the best there. But then this is actually, you know, when you do a pre-dilatation, you don't have to do rapid pacing. In a situation like this, I'd much rather avoid that, to be honest. I just would go ahead and place as quickly as I can to get the afterload relieved and then see what's going to happen. I wouldn't like to rapid pace.
But if you use the true flow balloon, you don't need to rapid pace.
Yeah,
So
I mean, obviously.
with
Lars,
this, it's got,
what's your comment on that?
I think Dan suggested about the true flow balloon. We can just explain. It's many sites use the true balloon, and it come in a version called True Flow. So it's actually have a channel in the middle, so you still have cardiac output while you're inflating it. So particularly in patients who are hemodynamic unstable, like the patient here in Bern, it would be a good option if you choose to do a pre-dilatation.
Well, I mean, you can also take the other stance and say, well, you might be relieving it, but you also might induce aortic insufficiency on top of it, and then you're really in big trouble.
I have to say that for in my practice, I do predilate almost 100% of the bicuspid case, but this typical patient, I would maybe not predilate and go, as you mentioned, Eberhard, directly with the valve. But here we have an extremely experienced and skilled team, and we see that they manage extremely well the patient. So let's see what is the outcome.
So you can see they're moving very fast now with the Envio, and now they're crossing the arch. Any comments from you?
And I would just comment the fact that the patient is in total anesthesia, and this is absolutely infrequent. I think this is due to the critical conditions. In a patient like this, it's absolutely essential to have a good anesthesiologic support, because the patient will need dobutamine, he will need assistance, and this is why he's intubated.
Crossing the valve now.
It's also a patient you can consider whether you actually need an assist device during your procedure here.
That was the next question there was having.
Yes.
Would any one of you have an ECMO there and stand by?
Probably, yes.
Lars?
That's actually
I think
what
that's
we
a for sure
have.
candidate
We
for
do
it,
have
because
an-
you see pressure was really low here. So
Yeah. So now they have to place the pigtail catheter in order to make sure that they have a good reference for the depth.
and hopefully the implantation goes well. But you know, sometimes in bicuspid valve you have to do several attempts before you have a good implantation position and well expanded valve. And in that situation, you'll gain some time having an assist device.
Yeah, and I have to say just quite briefly that this is the perfect device for this situation. You have a device that will allow a first attempt. You may keep the device attached in the outflow portion, allow the hemodynamic to recover, and then reposition if needed.
So they start between 4 and 6, do very slowly now for the first part.
I think it's, you know, I like the fact that they spend time getting that pigtail back in, because you know,
Right.
as we all know, it's absolutely fundamental to have that landmark, and particularly in this bicuspid anatomy. And we saw from the angiogram, as we'd expect with fusion of the right and the left, that there's a dominant non-coronary cusp, which is much deeper than the others. So they're going to be trying to, I think, implant, or at least I would, high relative to the base of that non-coronary cusp, looking to be kind of 0 to 2, which is not normal implantation depth, but in this anatomy.
Yeah, the valve expands now, and you know, they probably focus on the non-coronary to make sure that this is going to be good. This is about 6 now. Now he goes fast in order to relieve the tension. Excellent.
It's pretty deep.
So it's quite deep here.
Yeah, but it's not aligned.
Yes, we may. Yes, we will try to reposition this a little bit.
Unfortunately, this is
Obviously,
one of
the
those cases
patient
where
will
the
not tolerate
spines are,
this.
the spines are working against them. It's very non-coaxial relative to the annulus, isn't it? It's coming down that inner curve.
Yeah, here the position is nice.
Yeah, that's a good position. Probably you have to have to focus on the non-coronary, and on the right you can't. On the left you can't do much. So on the non-coronary to do that as high as possible, and then release it.
Okay.
And you can see that the heartbeat gets a little weaker. That's.
I think we need to. Yeah. I think.
But I think it's good to let the pressure recover a little bit. Okay. So they released it fairly quickly, as you can see.
It's really an emergency procedure.
Yeah.
This is not the way we do in elective bicuspid valves.
Yeah, I mean, it'd be interesting to see what other people on the panel think. I mean, our own practice in these high-risk cases is, okay, you've got to deploy quickly up to that, through the rumble strips where you're kind of 80% deployed, but you can pause at that point. At that point, you should have a well-functioning valve. It's not exactly the same as when it's fully released, but it's pretty close. So I personally would have paused at that point and aligned the valve, unless the patient remained clearly hemodynamically unstable. They obviously do have a blood pressure of 40 here.
Yeah.
But the valve should be functioning, so you can pause at 80%, and then if you need to do give support,
So we
even
can also
CPR,
look
you
in
can do it at that
echocardiography
stage.
now.
You can also consider now to try to re-establish the coronary flow, to give some chest compression here to bring the patient back.
But the blood pressure is
And,
gradually
we look
improving.
quickly
So.
with the
How about it's still very low?
echocardiography.
Getting better, and now at this point what we need is hemodynamic assistance with dobutamine is the drug of election, and some noradrenaline, which not creates too much
So the question from the audience here is using a balloon pump or impeller. Any words on that?
Yes, as you probably know, we have an assist device here as a backup. We have both an ECMO and an impeller. Actually, prior to the valve implantation, certainly the only option or the preferable option would be an ECMO. But when the valve is in place, actually, we could consider an impeller to unload the ventricle.
Watch the blood pressure now that is
This is probably the action of the anesthesiologist, that we see here now, which is a fairly typical situation, that they give drugs because they're concerned about the pressure, and then you have a little bit of an overshoot.
But to me, it just expresses the negative impact that these tight aortic stenosis had on the left ventricle, because now the patient is able to react to the drugs. So it's it's a really good sign. And you may expect some improvement of the LV function in the coming hours or days.
So at least at the first sight, you can...
Yes, Stefan. Yeah.
You see on the echo that obviously is very tachycardic because of the pressors he has received. But I think you already can appreciate a little bit that the LV function or the contractility, at least with the pressors, has improved. Yeah. Nevertheless, what you also appreciate now on the hemodynamics is the gradient is gone, or nearly gone, but we continue to have a severely elevated LV-EDP pressure. But maybe we quickly have a look at the echo just in order to assess our hemodynamics in terms of perivalvular aortic regurgitation. You have seen we repositioned the valve. I think it's a bit higher than it was previously. At the same time, as you probably know, the more you reposition, the more you lose in terms of hemodynamic reserve on the patient. So that's actually the reason we accelerated the procedure and released it in its current position.
But it looks, so at least from what we see here, Stefan, it looks on the first sight on echo, it looks kind of good, round and, not much PVL, at least not that.
So just would you, after the echo assessment, show us the fluoro in an orthogonal angle, just to see what is the stent frame expansion, just for the audience? And but you did a an exceptional job. It's marvelous, wonderful.
And this from DDA.
I think you see already a certain degree of circularity, obviously only in one plane with the echo, but we show you here the result also with the fluoroscopy. Maybe Thomas can rotate a little bit the fluoroscopy, and maybe Nicola, you can yes, okay. So we just rotate around the valve.
Stefan, this is very, very nice that you're showing this. I think this is a very important step that you're just showing us, rotate around so you can see really where and how the valve expanded.
Yes. So I think, the next step, usually what we would do is obviously in hemodynamic assessment, we need to look whether there is any paravalvular regurgitation. Maybe we can also look in the transesophageal echo in the LV outflow tract. I personally didn't see much, but maybe we can verify this once more. And then usually, obviously, we would now remove the catheters and do an access site closure. But in this patient, we will wait and we need to make a decision as to whether we will implant an impeller device. So while you continue the discussion, I will ask quickly anesthesia under how much pressors he currently is.
That's perfect.
Stefan, and the panel may have noticed this, it looks like you've got a great result with regard to AR, but the hemodynamics are showing something of a gradient, which obviously we wouldn't normally see, but in this bicuspid anatomy, It may be that you've got some frame under expansion at the level of the cusp fusion, and there may be a case of post-dilating if you do have a genuine residual gradient.
So let's do a discussion among the panel. Would you post-dilate in that case? Having seen that you have tiny regurgitation, it's trivial. You have an elevated LV-EDP, but due to the condition of the left ventricle, but we have some kind of distortion of the stent frame. Would you post-dilate in that?
I wouldn't post-dilate just for distortion of the frame, but if there's an associated gradient, which it looks like there is, I would post-dilate.
Eberhard, what would you do?
I agree with Dan. I would not post-dilate simply because it might look better afterwards. There has to be a reason to do that. In this case, I don't see it.
Flavio?
Well,
I think
normally in the implantation of bicuspid valves, I'd like to post-dilate. In this case, given the hemodynamic instability, probably the less you touch, the better it is.
The better it is for the specific patient, yeah.
I mean, let's say
honest,
this patient is special because he's so hemodynamic unstable. But otherwise, I would post-dilate in this case. You saw on the REO projection that it was constrained, the frame, and it's where as Dan was saying, where the leaflets are sitting. So in a standard case, I would say it might impair the durability of those leaflets that is not fully expanded. But this is a special case, and you have to take everything into consideration.
Can I bring this up, like leaflet thickening in a situation where you have an underexpanded valve and you don't really have good functioning of the leaflets? Is there, I mean, you guys are...
That's the main concern that I have with bicuspid. We've done some pre and post CT scan analysis of Evolut Pro, Evolut R in bicuspid, and when you post-dilate, the device definitely becomes more circular, and this may have a theoretical impact on the leaflet thrombosis and maybe durability for the future. Lars, you have most of the experience, a large experience in that field.
Yeah,
what
but
is
the
your
team in
feeling?
Copenhagen did actually a study on those self-expanding, and you can see if you have an underexpanded valve, those leaflets are more likely to have leaflet thickening, subclinical leaflet thrombosis. It's often in the right coronary cusp, non-coronary cusp, and also if you do a post-dilatation, you have less, as a general, less leaflet thickening.
So we might actually change our thinking a little bit on that, right?
Yeah.
As we learn.
Yeah. So in summary, for a regular patient, we would advocate to post-dilate for these reasons of more circularity of the device and maybe preventing leaflet thrombosis and promoting durability. But for this specific patient, it's up to you, Stefan, and maybe it is wiser not to post-dilate.
Yeah. You know, I think initially we did not want to post-dilate for all the reasons you mentioned, the hemodynamic instability. I also was a little bit doubtful whether the gradient we see here hemodynamically is a true gradient or whether we have some damping. So I think one thing we can do is that we actually flush our pressure lines once more. We will do this. But if that's not the case, I think what I can tell you from anesthesia is that overall the patient is doing hemodynamically somewhat better. Yeah. So Gabo just tells me that apparently the epinephrine, they reduced it to 200 microns and it was previously 450, 500. And I think what you also have seen maybe is that the separation of the end diastolic aortic pressure and the LV-EDP maybe has somewhat improved. So I think, you know, if anything, the patient has become more stable. Also, if I look at the echo, I would say the contractility probably spontaneously already, at least to my eye, looks better than these 10% or 50%. Yeah, well, maybe not. But I think overall he's doing better. So what I hear from the panel is that basically you would recommend that we post-dilate, and so I think we follow your suggestion and we'll do this.
It is very important that you. It is very important that you keep your own policy. You are in charge of the patient. So if your general feeling is not to post-dilate, don't post-dilate. If you do agree with us, we are happy with that. But you are in charge of the patient, you decide.
So Didier and Dan, if you look at the short axis of the echo, the valve looks pretty round, right?
Yeah. But I would still continue to post-dilate because I know that the Evolut Pro can achieve an exceptional circularity even in bicuspid. So I would tend to post-dilate my cases.
Mm-hmm. And you also had a gradient. You had a gradient of about, I don't know, was it 15 millimeter mercury?
Well, invasively invasively, it measured 13, but I think it doesn't mean anything in view of that depressed LV function. But visually we have seen that gradient, and yes.
So you're post-dilating, right?
We will post-dilate, but we will do this as short as possible.
Yeah.
And
what's the balloon size, Stefan?
that
It's a 26.
26. Yes.
26.
So Stefan, can you go to an
Perimeter
RAO
right,
projection?
diameter of
you
26, so
Okay. So what's the rationale? The first comment from Lars is whether or not to move to the RAO projection to see what is the overall expansion, and you are ready. And the second point, would you like to comment on the
Please,
rationale
ready.
for balloon sizing?
180.
You can do the BAV, and then we can discuss about which balloon size to use,
Pace on.
on which metrics.
Pace off.
off,
Pace off.
yeah.
We go in a little bit further.
Yes. A little bit
Pacer ready? Pacer on. Okay.
Good shot. Very nice.
Excellent. And we can see
Okay.
that the device is
Face
really
off.
more circular.
Yeah.
And that's what is wonderful with this platform. If you take time to reassess things properly and you are not afraid to post-dilate, it is going to become circular even in bicuspid patients.
And in terms of balloon type, it's worth mentioning as well that if you don't have the true flow balloon, the regular true balloon goes up and down much quicker than the other balloons.
Yeah.
It rewraps much more quickly, so you can keep the pacing time down to a minimum if you use the true balloon.
And there is one positive effect of that post-dilatation. You had some kind of foreshortening of the valve, and now it's in perfect position.
Yeah.
You have no regurgitation. We can expect that the gradient is going to be 0. So it's it was the right decision. The only concern that we have with post-dilatation in bicuspid patients is the risk of annulus rupture. So that's why the sizing of the balloon makes sense, and it's quite critical. Do you have a specific strategy, Eberhard, or what do you rely on?
Nulla, yeah.
No, I don't have a. I mean, it changed it. You know, I was following our algorithm from day one that we don't do it without a reason, post-dilate. But now, given the leaflet thickening situation, I think the roundness and the circularity puts a little bit of different spin to it. So we're probably a little bit more liberal and following your advice and your experience. And Lars, I think it makes a lot of sense to doing this.
But I think in terms of the sizing, you know, it's very important to distinguish this post-dilatation to most of the post-dilatation.
Correct.
Mostly we're post-dilating because of paravalvular leak, and we need to be post-dilating, you know, up to the size of the annulus. But here we're just trying to correct some probably significant frame under expansion, so we can take a balloon that's a couple of millimeters smaller than the annulus, and we'll still correct that circularity in large part without having to threaten the annulus with the risk of rupture.
Sizing the balloon, would that be your diameter? Because it was 25 point something.
Yeah, so
I
maybe,
think
yeah,
26.
avoid
Yeah, so
to
I might start with a
exceed-
24.
to exceed it, yeah.
Yeah.
So just a quick comment on the
So,
LV EDP,
Eberhard.
and it has decreased
Yes.
by more than 50%, and this is
Very
great
nice,
for this
Stefan.
patient. Yeah, it's amazing.
So I think you nicely see the hemodynamics now, and thanks to your advice, we put our strategy upside down. We didn't do pre-dilation, but we followed your advice to do post-dilation, and I think that probably saved this patient. But I think it shows two things quite nicely. One, that residual gradient wasn't true gradient, and that actually it has much improved. We just measured it. It's now a mean gradient of 9, and what Didier just mentioned, I think, is an important hemodynamic observation that now the LV-EDP is much lower. It's about 20, and you remember we started at about 40. So overall, I think this patient improves. We can once more look at the echocardiography, but there is no residual aortic regurgitation. And if you look at the LV function, maybe it is a touch better than it was at the beginning.
I think it's more than a
now,
touch.
as mentioned
actually.
before, you-
I think
Yeah.
it's really
and
has improved.
yeah. Yeah, you know, and I think it's a nice demonstration how malignant the disease is, because that patient, you know, we were on a search for a bicuspid valve. Basically, last Monday, the patient presented, and he was in heart failure, and he had a reduced LV function. But within just 1 week, he deteriorated, and as a matter of fact, he deteriorated just during the last 24 hours to a degree that he formerly was in cardiogenic shock. So I think it's also a good demonstration to see how malignant the disease is. Now, Didier and Eberhard, if you do not mind, we will still wait. We will not remove immediately the sheath. So although we could show the closure as we usually do it, I prefer to wait another 10, 15 minutes. If you wish, we can break away from here and talk to you at React PCR.
Just
we would remove our pigtail.
Just a final word. Do you think that there is room for a root shot just for the audience, or do you have concern,
yes, we will do that.
for that?
Yeah. No, we do that. But first, let's remove the pigtail from the ventricle, and then we remove the transesophageal echocardiography probe that you have some visualization. Then we do an aortic root shot.
Stefan,
that's what we, usually we wouldn't do the echo, and the patient would also not be intubated. The entire setup is only because the patient was so unstable.
I think, Stefan,
Nicola, maybe you can remove.
What is worth mentioning here is something that we might have forgotten, since TAVI is such a commodity at this point in time, what this technology really can do. This patient was extremely sick, and before TAVI times, this patient would have been in real trouble.
Wonderful, wonderful.
Oh, look at that.
So I think it also nicely shows the... it's really a good device for these kind of cases.
But I think, Stefan,
you have the ability to place it.
Yes.
Go ahead.
No. I mean, what TAVI can do in today's world with a very, very sick patient, experienced team, low flow, low gradient, unstable, cardiogenic shock, bicuspid valve, and we see something done in 20 minutes. And now you can discuss pre-post and all of this, but the patient basically has done extremely well with his team. A wonderful example of what this technology, this platform can do in a very sick patient. Wonderful, masterfully done.
So thank you. We would break away, and we meet you at React PCR in 1-2 minutes from now.
Thank you, and the whole team, Stefan. Very, very nice.
Whoa, so we had a lot of excitement here, so it was nice. So I think we have lots of things to discuss while they're preparing for the React at PCR. First thing, you can use the app to send your questions, and we'll try to answer them, to prioritize them for being answered. But the first thing that we may discuss before they join us is, what is the sizing policy in your institution for bicuspid valve? Because we know that there are multiple options, whether you size on the annulus, whether you size on the intercommissural distance, or tracing the theoretical expansion of the leaflets. There is no consensus. It could be interesting to get everybody's experience. So Lars, maybe we could start with you.
We try to measure both at the annulus size and also use the intercommissural distance. And often, if you do the supraannular measurements, you come to a lower number, and often step down in size. And I think that's the whole disease of the bicuspid aortic valve. This valve have never have a proper opening area from day one in life. So if you oversize, you may have issues about incomplete expansion of the stent frame, and also the radial force may sometimes pull the frame into the left ventricle. This case was quite straightforward because they get the same number whatever they did at annular sizing or supraannular sizing. And also, if you go around and see, some sites will use always supraannular, some will use annular, and in experienced sites you actually have good outcome with both measurements. So there's still a lot to be learned about how to handle these patients.
And if you have a discrepancy between the mean perimeter derived diameter provided by the annulus and the intercommissural distance, one is greater than the other one, what would be your sizing, your decision?
Supraannular.
The supraannular.
And particularly if you use, in some of those cases, if you use a balloon expandable, you should really be careful you don't have annulus rupture.
Yeah. Okay, Flavio?
I totally agree. It's a trade-off in between the LVOT, which will suggest to implant a larger valve, and the effective orifice area, which will suggest a smaller one. And this is the diameter we should prefer, trying to implant the smaller valve so that the opening of the leaflets kept well preserved, avoiding much distortion with a larger valve. And the other comment is also for me, the self-expandable structure is my favorite in order to avoid possible ruptures, even being very cautious with the post-dilation, which is always recommended in an elective case.
So we can see you now. Do you hear us, Stefan?
Yes.
Okay,
Yes,
that's
we do.
great. So once again, congratulations. It was extremely educational, extremely interesting case, and you did it in a perfect way in a very extremely fragile patient. So we have to congratulate you for that. The first discussion that we had was about the sizing, and Lars was saying, and also Flavio, that they do measure the annulus, the mean perimeter-derived diameter, and then consider what's going on above the annulus at the level of the commissures, and then they define a way, the size on both, and if there is a discrepancy, maybe the commissural, the intercommissural distance. So we've seen in your case, this type 1 left to right bicuspid, that all the metrics, whether it be the annulus, the intercommissural distance, or the surface tracing above at the level of the leaflets, was in a tubular configuration. All the metrics were concordant. So what was in case of discrepancy, what do you consider in your experience? More the annulus, the commissures?
Yes, I think it was a good idea to use both measurements. In our case, as we have pointed out correctly, we had very consistent measurements. We were in the upper range of the 29 Evolut Pro system, and I think that's the best case, right? In case you have a discrepancy between the two measurements, we still tend to use annular measurements, and we would certainly try to avoid oversizing, aggressive oversizing in such a patient, and rather tend towards the lower side, the lower range of the sizing chart.
A question to you too. I mean, we've talked about sizing, and I think we always agree what Lars and Flavio said, that there's a tendency of taking a smaller valve, considering the annulus and the diameter. But can you also elaborate a little bit on the depth? Because there are some investigators that say, operators that say, we would like to do it as high as possible, even if we are supraannular, because as we know, the anchoring is not the annulus, the anchoring is the leaflets or other leaflets. Is there any thoughts from your side in terms of depth in a bicuspid? Do you do anything differently?
Well, honestly, we don't do anything differently. We always try or tend to go rather high in order to avoid AV block and pacemaker implantation. So we always try to go a little bit higher. I think in such a case, in a heavily calcified case with bicuspid anatomy, in which you probably can anticipate that you may need post-dilatation, we tend to go rather 1-2 millimeters lower, because we observe that during post-dilatation the valve can come up a little bit. So I think we still implant with a small margin, but we don't go 4 to 6 millimeters. We try to go between 1 and 3 millimeters, but also in the cases that are tricuspid.
So one thing that we've learned,
as high as
yeah,
possible.
please continue. So one thing that we've learned from the live case is that we have to remain on the safe side, particularly if the patient is sick, and we nicely saw that you deploy the device across the annulus. And with the post-dilatation in mind, it ended up a little bit higher. But if you were above the leaflets, you would have closed the door for any post-dilatation. So it's more demanding. So I guess for those who are starting to treat bicuspid patients, the Evolut Pro platform is a good one, but maybe it is safer to deploy it across the annulus, avoiding to be too deep, as you did, and you nicely did for this case.
2 questions, Didier. Would you consider 24-hour impeller? And when discrepancy, is there any role for balloon sizing? Those 2 questions. Impeller 24 hours and balloon sizing.
The question comes to us.
So, what we will do right now, we will observe the patient, and I will have a conversation with the anesthesiologist, and afterwards we will make an assessment. What we have observed so far is that actually the contractility on the echo improves, that he needs less presses, and that overall he's doing better. And if that course continues, we will not implant an impeller. Conversely, if that would not be the case, we would implant the impeller just to unload him probably for 12 hours, something like this, and remove the impeller tomorrow. Now, the only thing, to be a little bit hesitant, particularly, let's say, in an ambiguous situation, and I think we have been in an ambiguous situation, is that we do not know what the impeller does to the valve during the, this 12 hours or whatever we do. You basically aspirate the blood from the LVOT, you eject it into the aorta. We do not know much what the interaction of the impeller with this prosthetic valve is. So my gut feeling tells me if I can circumvent it, I rather do not do it. Conversely, if the patient would not become stable, we would go ahead and unload him for 12 hours, 24 hours, something like this. I think in terms of access, he already has the large sheath in place, so there is no additional consideration there. I think our only consideration would relate to the valve.
Then there's another question from the audience. Does the left ventricular outflow tract would influence the balloon size, or is it the annulus only?
I think we rather go by the annulus. I mean, of course, if there is a huge discrepancy between the LVOT that can be very small in relation to the annulus, you may have a risk that the valve pops out during implantation. But still, we don't want to size for the LVOT. We rather size for the annulus. Even in those cases, tend to be cautious. But
so if we continue that,
to recapture the device.
Yeah, if we continue that discussion around the balloon, what is your experience, your strategy concerning balloon sizing, balloon predilatation with angiography at the same time? Do you do it? When and how?
Well, honestly, we hardly ever do this. Maybe it is a good option in cases with a very asymmetric annular plane. Maybe there it is a good option. We rather try to avoid it.
I think where it could help you is where you have a discrepancy between the annular and the supraannular measurement, and where you could then make up your decision between for the size using this. But as Thomas says, we rarely do it. We usually predilate, but not for the purpose of balloon sizing, so not to the annulus size.
Well, a very brief comment regarding balloon sizing on LVOT. Patients with very depressed LV function have dilated ventricles, and the LVOT might be very big to size the balloon, which would become too aggressive. So I agree that we should stay on the measure of the annulus size.
So let's do for a round panel discussion. Lars, what would be, as a summary, the main teaching point of this live case that we've seen from your side?
Yeah, but I think the live case actually turned out different than we planned. It should be a live case around a bicuspid aortic valve. It turns out to be a TAVI in a patient in cardiogenic shock. So, but if we start with a bicuspid aortic valve, I think we have discussed the sizing of this, and I think you need to maybe size both at the annulus level and the supraannular level. And you said, Flavio, sometimes a balloon inflation with simultaneous aortic root injection will also give you additional information on what size balloon valve you should need. Implantation probably needs to be a higher position. Just to comment on you, if you look at the stent frame, you dilated very nicely up. You saw it was not constrained at the annulus level. It was constrained at the tip of the leaflets. So it's actually this point at anchoring. It is not anchoring as much at the annulus as on the cuspid by itself.
Dan?
Yeah, well, I was expecting you to go along the panel they give me, did you?
Yeah, but you are,
Well, I mean, I think Lars summed up most of it. I would agree with Lars, actually. I think, we do position higher. It is different bicuspid anatomy, I think there are differences in the approach. And if you're measuring above the annulus, then that implies that you're using the anatomy above the annulus to seal and anchor the valve. So it doesn't make sense to me to measure above the annulus and then deploy in exactly the same depth. So we would measure the annulus, we would undersize against the annulus, and we would deploy slightly higher. I think the other thing about the anatomy, and in this case showed that, is that we saw a very deep non-coronary cusp. If you would have deployed against the non-coronary cusp, you would have been very deep against the left and right. So you did a perfect job, which was right at the level of the base of the non-coronary cusp, and that was a good depth. So we would do this approach, which is undersizing relatively and deploying high at the level of the annulus. And in fact, I think you can be confident in post-dilating, even if you're supraannular, that the valve is anchored firmly within those fused cusps. You're not going to embolize the valve post-dilating in a bicuspid, in my view. I've never seen that anyway.
Yeah, I would.
Yeah.
Question from the audience for you guys. Do you have any tips in case of annular rupture during post-dilatation? This is a tough question.
Yes, we don't like to see annular rupture. As you know, that is associated with a grave prognosis, and obviously you consult with the surgeon. Now, in this patient, for example, he is in such a critical condition. He is clearly not a surgical candidate. You also would not do a conversion. I think one thing you can try is implant a second valve, and in trying to seal the annular rupture, I think that would be one approach, and one other option would be, in case the patient is sufficiently hemodynamically stable after you have done a pericardial puncture, is that you've tried to close the tear with an Amplatzer plug and so on. So these are kind of things you may try, but I think, out of personal experience, I must say a lot of these cases, they end fatally, unfortunately. I think in this case, however, the risk for annular rupture was very low, because the distribution of the calcification along the leaflets was more central and not at the outside and towards the aorta. So I think in that case, I think that we were not worried about annular rupture.
Yeah. Stefan, the questions are popping up right now. So which kind of anti-thrombotic regimen do you choose for this patient? Anti-thrombotic therapy.
So, during the procedure, we obviously use unfractionated heparin, but in this patient afterwards, with such a depressed LV function, atrial fibrillation and everything, we will use oral anticoagulation. Usually what we do is, if the patient doesn't have a contraindication, that is, he has severe renal failure, that we give a non-vitamin K oral anticoagulant.
Can I also ask a question, particularly in view of Professor Meyer, Bernie, what his opinion about valvuloplasty is? There's a question here, did you consider balloon valvuloplasty alone?
No, actually, that would be misquotation of Bernie.
No, Bernie, I know that.
He never believed in balloon valvuloplasty.
That's why I'm asking this.
And I think he does not think this is an adequate therapy even for bridging. So in the spirit of Bernie, we would abstain from that. And I'm glad we also followed your advice that we did not even predilate the patient. Yeah.
There's been some nice data, registry data, looking at BAV versus TAVI in cardiogenic shock, showing that the mortality of the two procedures is pretty similar. But of course, with the BAV, the patient then comes back, if they do survive, for a TAVI, and then they take another morbidity hit. So, that would support your suggestion. It's better to just go straight to the TAVI, even in these cardiogenic shock patients.
Stefan, a quick look into the future. Do you think that our post-implant therapy would change in the future? Direction, no anticoagulation? What's your crystal ball?
I don't know. I think there are a lot of things that speak for anticoagulation, but I think one thing we need to keep in mind is that we still treat very elderly patients. So, for example, this patient is 88 years old, and I think at the end it will be the balance between protection against valve thrombosis, stroke, versus bleeding events. So I think the jury is open in patients who have atrial fibrillation. I think it's clear. In all others, I would not dare to make a recommendation at this point in time.
So perfect. You are perfect because you also respect the timing. We have 30 seconds to congratulate you again, and it was a fantastic job, a fantastic discussion and very educational case. So we all give you a big round of applause.
Thank you.
Okay. So I guess we have to continue, recover after this live case and continue the session now.
I think it's you, right?
Yeah, it's me. Okay.
So you are building an efficient TAVI pathway from screening to discharge and follow-up. The experience, Clinique Pasteur, but matter of fact, it's the experience of Didier.
So it's a recorded case that we did exploring the pathway of a typical TAVI patient, and just to discuss how we ended up for being efficient and optimizing the overall TAVI program. So it will be a substrate for our discussion afterwards. Can we see the video? En régie, vous pouvez lancer la vidéo. Bonjour.
Bonjour.
Nice to meet you, Didier Tchétché.
Nice to meet you.
Okay. Come with me, please. I've read the report from your doctor. So you're 82 yes. years old. And do you have any past history, medical history?
Nothing particular.
So
no.
Nothing particular. So in summary, you have an aortic stenosis that is a really frequent disease, age-related, lethal, but easily treated, with two options, surgery or TAVI. So what we're going to do is to organize an hospitalization for that series of tests, and then we will decide what is the best option for you. This is Adeline. Adeline is our valve coordinator. She's going to explain everything to you afterwards. You're going to go through a series of tests to make sure that we have all that we need to select between surgery and TAVI, as I told you. And then we will make a synthesis at the end of this period. It's going to take only 2 days. In 2 days, you will have a final decision on what to do, and then how to do it, and when to do it.
I'm here to plan all these exams, to collect the data. Once we will have all the results of the exam, the heart team meeting will occur, and they will decide if you're gonna have a surgery or a TAVI procedure.
Soufflez là. À fond.
You've already seen his history, but roughly 82 years old, not overweight, hypertension. He's in sinus rhythm, which is good. Some kind of renal failure, significant aortic stenosis, and we see that he has depressed LV function, mildly increased systolic pulmonary arterial pressure, and no major MR. So this is the kind of standard candidate, and we will have to discuss whether or not to go for surgery. So these are some snapshots of the echo. We can see that even though the left ventricle is depressed, there is a kind of septal hypertrophy. The left main has a very tight stenosis. The left circumflex is occluded from the ostium, and there is no major disease, maybe some diagonal here. And the right coronary artery overall is fine. The peripherals are fine. the aortic arch is quite normal. The aortic annulus is in the range of a potential TAVI valve. He is a kind of intermediate risk patient, at least based on the risk score. So let's start with you, Olivier, as you are the surgeon.
For surgery, it seems for me that it's quite a high risk patient. If there is only the valve to do, it would be possible. But I think that the good option is first to do the angioplasty of the two vessels and then to, I think, the TAVI.
He's 80-year-old. He has a renal dysfunction and that could be decreased after the surgery. He has coronary disease. I think it's the best strategy would be TAVI.
Okay, so for you also it would
Yes.
be TAVI. And so I guess do you agree with that?
I perfectly agree. And on top of what you said, I would just add that the last argument, to my opinion, is that from an anatomical point of view, it's a good candidate for both PCI of the left main and for transfemoral TAVI. He has good vessels, simple anatomy, annulus dimensions that are in the range of the transcatheter heart valve we have, so an anticipated low risk of complicated TAVI patient.
And Lord, do you agree that we can do local conscious sedation for this guy?
Yes.
There is no need for general anesthesia. So okay.
It's better for rehabilitation.
Okay. So I will go back and see him with Adeline, the valve coordinator, and to tell him that we've decided to go for TAVI, PCI before, and then we will do a TAVI procedure. It's certainly going to be an Evolut R34 because it's a large anatomy. Hello, good afternoon, Mr. You well?
Hello, yes.
And we have decided to do a TAVI procedure for you. When we first met 2 weeks ago, I told you that one option could be to go from the groin. So in fact, I have a couple of explanations for you. So it will be under local anesthesia with a mild sedation just to avoid any pain for you. We're gonna go through your right groin with a catheter. That is a kind of tube that will reach the heart. And we will put that tube in the middle of your diseased valve and then expand the new valve. This is the TAVI, the concept of TAVI. You will also have another access through the right wrist. We've gone through the right wrist just to do the coronary angiogram, and we will use the same access just to prepare the placement of the valve and to see where to land the new valve. The procedure will take about 30 minutes. We are going to use that valve. That is the one that is contained within a catheter and that is expanding by retracting the external, the outer layer of the catheter.
Okay.
So luckily we will meet again in 2 weeks.
Hello, how are you today?
I'm feeling good, thanks.
Okay, so I'm here because Dr. Tchétché told me that you're gonna have a TAVI procedure, a valve replacement. So my job is to collect all the exams you have done during this hospitalization and to see if we've got all the data required for the intervention. And I'm here to see if to plan the next hospitalization for the intervention. Usually in 15 days we'll be able to plan an intervention, but I will tell you the exact date.
So this is the finish line. Tomorrow is a D-Day. How do you feel today?
A bit nervous.
Nervous, that's normal. So I will do the procedure tomorrow by 8 a.m. Everything is fine, you're set, so I'm going to scrub in, and then we will start the procedure with my partner. Okay? Okay, Mr. Are you fine?
Yes.
Okay, excellent. So can you watch the screen? So this is the valve that we've just deployed. It's perfectly at the right location, and there is a normal function of the valve. So we took the pressure from part to part of the valve, and you see that metallic frame is the valve, and outside you have the leaflets. So everything is perfect. It's great. So we're going to put you in the recovery room, and then you will go to the ICU. Okay?
Okay.
Excellent. So I will see you in half an hour. So it's been 1 day, so it's nice. I'm going to check your heart rhythm.
Okay.
So what we're going to do is just to help you stand up, and then you're going to walk with us a couple of feet just to make sure that everything's fine. Okay?
Oh, okay.
Is it okay?
Yeah.
Perfect. Okay. So I will see you in 2 days, 2 to 3 days, just to make sure that everything remains fine and you can be discharged. It's been 3 days after the procedure and everything is fine. The echocardiogram is fine. And one concern we had was about the heart rhythm, but there wasn't any event, so we can discharge you today. And the groin on the right side, the right wrist, everything is fine. And then I will see you in 1 month. Yeah, okay. There is always a visit at 1 month and 1 year with an echocardiography, an ECG, and a consultation with myself. If you don't mind, you will see me again in 30 days.
I look forward to seeing you again.
Okay. So I wish you the best, and I will see you in 1 month. Okay?
Thank you very much.
Take care.
Bye-bye.
So good evening. It's a real pleasure to see you 1 month after the
It's good
procedure.
to see you again.
So how do you feel?
Well, I feel remarkably well.
Oh, it's good.
It's amazing how things have changed.
So do you walk without any shortness of breath, things like that?
Yeah, I can walk normally, and more particularly, I can climb stairs without getting out of breath.
Oh, that's
that was a real problem for me beforehand.
That's excellent.
And apart from that, I feel generally very good.
Okay, so that's very nice, very nice. So I've seen the echocardiography that you've done, and it's perfect. So there is a large opening of the valve. There is no regurgitation. In terms of medication, you're going to remain under aspirin and clopidogrel for 5 remaining months, and then afterwards, clopidogrel is going to be discontinued. For the time being, you should take an appointment with your own cardiologist. And we will see you again in Pasteur in 1 year. And we will do exactly the same thing with an echocardiography before coming to the consultation, and we will do an ECG. So it's very nice, and I'm really happy for you, and it's good to see that we may provide benefits to the patient and health indeed. And quality of life. That's the most important.
Yes, I'm very grateful to you, doctor. Thank you.
Je vous dis bon vent, all the best for the future.
Thank you very much.
So, Didier, that was a beautiful example. Now, before we come to the Danish experience, let me ask you a question, actually the whole panel, Dan, and to the left and the right. When you take into consideration that 60% of the patients that are being readmitted due to some kind of cardiac symptoms, heart failure, rhythm, something like that, 60% is the reason for that. Would you see in the future, not maybe now, but in the future, see that there should be a monitoring system that allows the patient, or that allows the center to monitor the patient and see what's happening with that particular one with regards to the heart before it gets into the situation of being to be readmitted? In other words, monitoring post-implant, would that make sense to you?
I must admit I wasn't aware of those data. I'm a bit surprised it's as common as that. I'm not sure, Eberhard. I think there are some things after the procedure that we could do better. I think rehabilitation is an important thing. This patient was a fit patient, and there's a small pilot study going on in the UK at the moment looking at rehabilitation for TAVI patients, and I think they're a population who can really benefit from that. I think we've got some concerns about late conduction disturbance and arrhythmias that we haven't quite got a clear handle on. So if we could monitor heart rhythm and we could make sure we're not missing patients with late AV block, we know there is an instance of late sudden cardiac death. So I think there are some things that we could work on there for sure.
Yeah, and I think that's it's important also to try to really have a short hospital stay, so you don't need that much rehabilitation, and also to have a close follow-up of the patient. We often leave a stitch in the groin afterwards, ask the patient to go to the GP after 1 week to have that removed. Not as much for the stitch, but just to have a checkup. And I also think the new European heart guidelines for valvular heart disease also have implied that you should do as you do in Pasteur, see the patient after 30 days and at 1 year. So I think not only do the procedure and then send the patient home, but make sure there's actually a close follow-up on the patient. And if you can't do it yourself, you need to have some close collaboration with other hospitals who can take over and follow the patient.
I think that is really crucial. You need to create a network, and that's what we did. And the valve coordinator is really important because it's the person that is going to organize everything, make sure that everything is scheduled in the right way, that gets into contact with the general practitioner and the cardiologist just to make sure that after the 3 days of discharge, the patient is not put into the nature without any follow-up. And one thing that we've learned is that we have to prepare also the family, the relative of the patients. So the first time we see the patient in the hospital, the valve coordinator gets into contact with the family, just to explain to the relatives that the patient is going to be discharged home and that the hospitalization for TAVI is going to last only 3 days. So if the patient is prepared, it's easier to discharge him on day 3. Otherwise, he wants to remain in the hospital.
You want to mention, because I mean, we're all in agreement of that. My point is, now we depend on the symptoms of the patient to call back, either go to the physician or call back the valve coordinator. If we had something like an implantable device that you can monitor independent of patient symptoms, would that potentially make sense to avoid, delay in treating complications? Never thought about it.
I don't know.
Yeah, but I mean, I think those, I haven't seen the data, Eberhard, but I'll guess it's not only arrhythmia that are coming back for heart failure. Quite a few of these elderly patients will also have bleeding complications. There may be an AFib and go home on anticoagulation treatment. So I think there's a lot of different reasons which is going to bring these elderly patients back to the hospital. And I'm not sure you can capture everything by monitoring, but I'm sure you could capture some of it.
Didier, I had a couple of questions about that specific case. It was, I mean, you had a beautiful pathway, but two things that struck me about the timings: CT and angiography. You obviously did those in successive days. Are you happy with that in terms of contrast? And the second was around the timing of PCI and TAVI. What's your preferred delay after PCI until you go into TAVI?
These are two extremely important questions regarding the risk of renal failure for the patient. If we have a patient with a depressed renal function at baseline, we may extend the screening phase to 3 days, just to split the contrast dose in more prolonged period. Otherwise, in our experience, with an adequate CT acquisition protocol, we can do the CT, first the angiogram and then the CT 1 day, after one day. So it's very easy, and we have no experience of acute kidney injury depending on that. So it's all a matter of organization, preparing the patient if needed, and if we follow that sequence, most of the time it's fine. For PCI, our policy now is more to do it at the same time of the procedure, because we want to be efficient. If we prepare, we keep the patients 3 days for PCI, then TAVI, or another hospitalization, we have the feeling that we are not so efficient anymore. So we try to do it at the same time. Okay.
So just one question, Didier, you can read it with the pacemaker.
So do you place the pacemaker from the groin as well? So we don't, in our experience, and maybe Lars is going to show how a streamlined procedure is going to be done in his institution. In our institution, we don't place any right ventricular lead for the procedure. We pace on the left ventricular wire. So all the patients have no right ventricular lead. So if we don't have any conduction disturbance during the procedure, huge enlargement of a pre-existing left bundle branch block or complete AV block, we don't put any right ventricular lead. So the patient is discharged to the ICU with no right ventricular lead, sitting on a chair after 4 hours, and then walking 24 hours after the procedure, so just to keep efficiency.
So we have a couple of other questions, but I think
it's time to move.
Yeah, it's time to move on, and we call on Lars, Professor. Danish experience, or I should say Copenhagen experience.
Thank you, Eberhard. So, I'm going to say, tell us how you can streamline your TAVI procedures, and this is mostly from Copenhagen. Of course, it's going to be different from region to region how you can organize your TAVI program. But the aim of a streamlined TAVI program is to provide a faster, simpler, and cheaper procedure without compromising on the procedure safety and efficacy. And of course you need, Didier showed it, pre-procedural workup, patient-specific planning, simplified procedure itself, and also the post-procedural care. So if you want to do it as a streamlined, a very simple case, you want to do it as a transfemoral case, and it's very important you have a good measurement on the CT scan before whether you have the access vessel which is going to allow you to do it as a transfemoral case, sizing of the annulus, and see if any specific anatomy, in this case a bicuspid aortic valve, is also very important to know up front. We also have a valve coordinator, nurse specialist. We actually have 2 specialists every day working with these patients, so we don't spend as much time as DG with the patient. They do all the workup. We ask all the referring hospitals to provide us with the angiography, with the CT scan, with the echocardiography. So when the patient is referred, all the workup has been done. And the patient mainly seen this nurse specialist in the outpatient clinic. And one of the things he's doing is to see if the patient actually is not too futile for the procedure, but also before the patient is admitted to the hospital, start to plan how to get this patient home again. So you cannot bring a patient who is 90-year-old home the same day if you haven't planned it. So you need to have a plan for how to get the patient home. And TAVI simplification is more like we did in the very early days with TAVI, where it was almost like a surgical setup with anesthesia, with a heart-lung machine, surgeons in the room, general anesthesia, to try to simulate a PCI procedure with very few patients in the room, procedure done in local anesthesia. We don't even have an anesthesiologist in the room during the procedure. Do it as a transfemoral approach and send the patient home back to the ward after the procedure, not to the ICU. So these are the tools you can do it. Again, as I said, local anesthesia, transfemoral route, make sure you have a proper vascular access and closure, because that's often the main complication after a TAVI procedure. You can do echocardiography, even if you have it in local anesthesia, you can do an intercardiac echo if you want. And also we're coming back to the pace lead, which is often a factor which is keeping the patient in hospital after the procedure. So the local anesthesia offers you several advantages. First of all, you don't need an anesthetic team. We only have a scrub nurse looking after the patient, so it's a much more flexible scheduling of the procedure. If you have a patient you want to do, you can just bring him to the cath lab. You don't need to have arrangement with the anesthesiology department. Patient will be more hemodynamic stable in local anesthesia than in general anesthesia. And as I said, the patient don't need to go to an ICU afterwards. They can go straight back to the ward after the procedure. and also imply a faster recovery after the procedure. And another important issue with local anesthesia is that the patient will often tell you if there's a complication. If you have a vascular complication, the patient will give a notice, where if you have a patient in general anesthesia, it often revealed until the patient is awake again. On the other hand, to have anesthesia in the room is of course ideal in an emergency situation, where local anesthesia means that you have to call for help if you have a problem. We all want to do it as a transfemoral approach, and this is just a meta-analysis of the 4 available randomized trials last year, 2016. And you can see if you do TAVI compared to surgery, you have a 13% reduction in all-cause mortality after 2 years. And this is not a small number of patients, it's almost 4,000 patients. And it's all driven by transfemoral approach. So if you can do it as a transfemoral approach, you have a 20% reduction in mortality compared to surgery. If you do it as a transthoracic approach, it's similar. But try to treat too many patients also imply a risk of vascular complication, as in this fatal case. But with the new system we have seen, you can have expandable sheet, inline sheet, so you can actually nowadays treat more and more patients as a transfemoral approach, and I think most institutions can handle about 95% of their cases via a transfemoral approach. And also vascular access and particularly complication is an issue. It both prolongs the procedural time and the length of the hospital stay. So it's very important to have a very ideal puncture of the vessel. So first of all, you need to look at your CT scan to see where's the right place to puncture. More and more sites is now moving to do it ultrasound guided, to have a puncture without any spot of calcium and in the middle of the vessel. And there's also a new closure system available. So in the past, most sites were using ProStar or ProGride, but we know that about 20% of those cases have a failure. You need to do something else. You need to do a balloon inflation, maybe even a covered stent, or in worst case scenario, you have to do to call for your vascular surgeons. So a new system is coming out. This is just one of them, the MANTA system. It's actually just like an angioseal, just in a much bigger size. So you don't do any pre-procedural things. You only measure the distance from the vessel to the skin. And when you have done your procedure, you put it in, just like as with an angioseal, have a pedal coming out, and then you have a collagen plug, which is going to close the vessel. And it's very efficient. You have, at least in our experience, we've used it for about 50 cases now in Copenhagen, a much lower complication rate. And it's going to shorten your procedural time. It's going to shorten your hospital stay. These patients can be mobilized a few hours after the procedure itself. As I said, we have in the selective cases, if we do it in local anesthesia, we cannot in Copenhagen do transesophageal echo, but we can do intracardiac echo if you think that's needed for the patients. This is just some example here. You can get the short axis of the view of the valve before the procedure and after the TAVI valve has gone in. And you can also monitoring the procedure, look at the LV function, look for pericardial effusion during the procedure. So you still have in local anesthesia the options to have echocardiography guidance of the procedure and monitoring for any complications. Pacing is also an issue, and you saw the case from Toulouse. Tchétché showed that you can pace on the stiff wire in the left ventricle. So you have the wire sitting in the left ventricle as one part of the pacing. You see here the electrodes are connected to the guide wire down here, and you have a needle in the skin down here where the other electrode is connected. But one important thing, if you want to pace on the wire, you need to have isolation between the two pacing points. So you can only pace if you have a catheter on your delivery system in place. The minute you pull out your delivery system, it's not going to work. So you have to make a decision immediately after the deployment whether you need to insert a temporary pace lead from the venous access, from the groin, before you remove it. And also, one of the things which is often keeping the patient on the ward or in the hospital is the concern about late conduction subnormality. You know there's a short distance between the aortic valve and the membranous septum and where the conduction system is. And here you can see the deeper you implant, the higher is the risk that you're actually coming below the membranous septum and you touching or is impeding on the conduction system. So you, of course, need to implant as high as possible. And this information is actually available on the CT scan. So you can measure up front what is the length of the membranous septum. In this case, 3 millimeter. In this case, 13 millimeter. So despite it's the same implantation depth, one patient had a 3rd-degree AV block, one didn't have any conduction abnormality. So this may be a tool in the future to screen your patients and to see how high do you need to implant the valve and what is the risk for conduction abnormality. And also, in the cath lab, you can actually use very simple algorithms to see if the patient is at risk for late conduction abnormality. So if the patient is in sinus rhythm and you immediately after the implantation take an ECG, PI interval is less than 200 milliseconds, QS duration less than 120 milliseconds, you can remove the pacelead. This patient will not have late conduction abnormality. If the patient have a PI interval more than 240 milliseconds, or less than 240 milliseconds, and QS less than 150 milliseconds, you can still remove it. The patient is not going to have late conduction abnormality without any escape rhythm, but he needs to be monitored on the ward by telemetry or by daily ECG. Atrial fibrillation, the number is QS, less than 140 milliseconds, and you can safely remove the pacelead. So this also gives you a tool to get your patient home early on. So Streamlining TAVI allow you, again, a faster, simpler, cheaper TAVI procedure without compromising both efficacy and safety of the procedure. It requires proper pre-procedure planning, and often preferred access would be a transfemoral approach. The procedure may be simpler in many aspects, as I show you, and planning of discharge is very important before the patient admitted. In our institution, we have about 40% of the patient home day 1 after the procedure, and 80% of the patient is home 3 days after the procedure. Thank you.
Okay, thank you very much, Lars. If you have any question, please feel free to populate them on the app once again. So maybe we can start with that question, Lars. So after discharge, do you have any patient information leaflets provided to your...
And we actually don't. I think it's a very good suggestion. But again, we have those 2 valve coordinator, nurse specialists, which is in close contact with the patients. Because if you want to send some of the patient home very early on, you need to have a close contact with them so they can also bring the patient back to the nurse outpatient clinic to have assess them, or they can give them a phone call to see how things are doing. But I think a leaflet information would be a good idea for these patients to what to react on.
We're just trying to go through the questions, Lars, because it gives us a little bit time to react. Is that okay, Didier?
Yeah, it's okay, it's perfect.
So can one of you go through the questions here? If the choice of surgery, how do you consider patient preference?
But I mean, if you look into the European guideline, you have a number of both clinical issue and anatomical issues, and you also have patient preference as one of the things which you should weigh towards surgery and TAVI. So I think you need to sit down with the patient and say, you may still fulfill the criteria for surgical aortic valve replacement, but if you have a very strong wish for a transcatheter procedure, I think that's the way forward today.
Dan, patient preference?
Yeah, no, I think it's important. It's very important, and usually it's in the direction of TAVI, isn't it? And I think it does depend on how you speak to the patient and how you put the different options to them, and so you have to. I think you have to guide the patient and then take into account what the patient thinks. I'm sure we've all had patients, even early in the days of TAVI, who were clearly solid surgical candidates, even younger patients who wanted TAVI, and we've sometimes said to the patient, we're not going to offer you TAVI, a healthy 65-year-old, we think surgery is the right thing. So I think you have to have an open discussion. You definitely need to take into account patient preference, but you need to make sure you're giving the patient the right information in an open way.
Flavio, would you address the next question? Yes, calcification up here.
Do you assess the calcification burden of the thoracic aorta before the procedure?
Yes, we do. It's not only about the AV block. I mean, calcium in the aorta may create several complications, from stroke to annular rupture to mitral insufficiency. And of course, this has to do with the choice of the type of valve. Again, the self-expandable valve is the softer type of valve you can implant when there is a lot of calcium, especially if there is an uneven distribution of the calcium. And this is one of the issues we discuss in our teams when we decide the type of valve that will be implanted.
I think it's a good question, though, because it seems obvious, but actually we were definitely in our centre guilty of looking really hard at the femorals and the iliacs and looking really hard at the valve, but not really looking too much at what was in between until we had our fingers burnt and realised that it is important to look at the rest of the aorta as well, because you can get into some real difficulties, as you all know, with delivery of the valve around a diseased or tortuous aortic arch.
Lars, the question, when do you not discharge the patient? That's the next question. You talked a lot about discharge.
Yeah, but again, I showed you this algorithm, and it will allow you to remove the pace lead in about 90% of the patient in the cath lab. And the remaining you have to observe maybe 24, 48 hours, and if the conduction stability is not going to become any more severe, you can remove the pace lead and you can send the patient home. I will say that's one thing which should maybe raise concern, and this is the patient with right bundle branch block. So despite they don't have any further conduction abnormality after the procedure, there are studies out showing now that these patients actually have, within the first couple of months, about 20% increased mortality. So I think we need to study a patient with right bundle branch more carefully, and maybe all of these patients, it's about 10% of the TAVI cohort, deserve a permanent pacemaker.
I would also add to keep an eye on patients with low-frequency atrial fibrillation, because this is one of the other variables that develop very low bradycardia. If it's not a total block, but sometimes they become very bradycardic after the valve.
So this is a very important topic, and we can see that there are several questions from the audience about the criteria for early discharge and to safely discharge the patient. But we have to move forward. So now Dan is going to talk about the strategies and practical tips and tricks to minimize the risk of TAVI.
Okay, great, thanks. So I'm going to talk a little bit more practically now about TAVI complications, how to avoid them, and try and illustrate that with case presentations where I can. Forgive me, it's going to be a bit of a whistle-stop tour. These are my conflicts of interest. So what's the key thing to minimize TAVI complications? For me, it's pretty clear-cut. It's about pre-procedural planning. And certainly in our program, when something goes majorly wrong, almost invariably we can look back and there's been a failure in the planning and the strategy that we've had before the procedure. That's where we got it wrong, not during the procedure itself. And probably the most important element of that procedural planning is the CT, as we've been discussing. Looking at the vascular access, looking at the pathway to the heart, the risk of annular rupture, the calcification, not just at the annulus. All of those things are guided by the CT. So we can divide perhaps major TAVI complications into those that are catastrophic. These are the things that might kill the patient or leave them disabled, or those relatively common but still important but less catastrophic things. I can't deal with all of these in the time frame, so I'm going to focus on these 5. So what about annular rupture? My theme is going to be identifying these patients in advance. You need to see which patients are at risk of annular rupture. The highest risk almost certainly are those with LVOT calcification, particularly when the pattern is protuberant and or there are multiple nodules, so you can't just push that calcium out to one side. Annular calcification also confers a risk, and it's easy to forget about sinotubular junction calcification, where you can rupture the root with a balloon expanded valve or during post-dilatation. I think once you've identified that a patient is at risk of annular rupture, you need to use a self-expanding valve. There's no point taking a chance with balloon expanded. And try to avoid post-dilatation, because that's how you can rupture the annulus even with a self-expanding valve. We've certainly done it. I think along the lines with that, you need to accept some paravalvular leak if you have to. You won't kill the patient with paravalvular leak, but you will almost invariably if you rupture the annulus. So here's a case that we had earlier this year, which was clearly at high risk of annular rupture. You can see there's severe calcification of the annulus in the top left there. There's 2 large bars extending into the LVOT and severe cusp calcification. And to make matters worse, we've got a big annulus with a derived diameter from perimeter of 30.5 and 30 by annulus now area. We decided to use a 29mm Sapien 3 with a very conservative deployment, we ended up leaving 3 mils of contrast in the syringe, and we're patting ourselves on the back when we saw this end result with no post-dill and not much AR. Unfortunately, 2 hours later, there was hemodynamic collapse, tamponade. We had to emergently do pericardiocentesis. Bleeding continued. This patient was not fit for surgical bailout. We decided in advance, and we spoke to the family. Now, there was a miracle and the bleeding stopped spontaneously. Probably it was a small rupture because we were conservative and the patient survived, but this is the exception, not the rule. About a month later, we had this case, very similar anatomy, perhaps slightly less fearsome, but still a lot of calcium, as you can see, around the annulus, a bar extending into the LVOT, and very severe cusp calcification, and again with large anatomy, 30.2 by perimeter, 29.4 by area. Now, having had our fingers burnt, this time we used a 34mm Evolut R valve, which we deployed and post-dilated a bit, but not very much. And we had this result. Now, we do probably have moderate AR here. If we had a 34 Pro, maybe we wouldn't have seen that. But we hadn't ruptured the annulus. We had good hemodynamics. This patient tolerated this fine, did well, went home early, and her breathlessness was resolved. What about vascular complications? Again, pre-procedural planning. Identify high-risk patients, not just vascular anatomy, but obesity, which is a major risk factor for vascular complications. Then think about valve selection, looking for low French size and also flexibility of the delivery system. Are you going to go with a sheath or sheathless? And think about non-femoral access. And I say safety versus feasibility because it may be possible to get up the femorals, but might it be safer to go through a large, healthy subclavian artery in borderline cases? So think about what's safest for the patient rather than what's just possible. Here's a case we did recently, which was tailor-made for the Evolut R system, where we had small, calcified, but fairly straight iliofemoral vessels, minimum diameter of 5.1 millimeter on the better side, which is the left. We were able to negotiate this very easily with an Evolut R system. I think when you have straight anatomy, the sheathless system is good. It's stiff, it pushes through small anatomy. But when you have tortuous calcified anatomy, we favor a sheath because of the stiffness of the sheathless system. And usually we would actually use an expanding sheath, such as the Edwards E sheath, with an Evolut system to keep caliber down. Use a long 14 French sheath up front, always in borderline anatomy. And when you exchange for the sheathless system, if you are going that way, then we will tend to take the 18 French Cook dilator to reopen the path. Lars has already told us about vascular access and closure, and I think here it's just key to use rigorous technique, particularly in high-risk cases. You can use ultrasound guided, which is an excellent method. We will still commonly use a crossover technique, as shown here, where we take a picture with a pigtail, and then we know we can perfectly puncture in the middle of the anterior wall, avoiding any side branches or calcification. This also enables us to place a supportive wire, an 018 wire, such as a V18, and leave that down the femoral artery. Now, we tend to do this in every case, but you can do this selectively. You can still do this if you go radially, as Didier does. The wire is long enough. And this will enable you to deal with minor bleeding easily, but it will also help you when you have big problems. Here's a case on the left where we actually used a Manta, which is an excellent device, which we're using routinely. But this was a rare case where there was occlusion of the common femoral after the Manta was deployed. If we hadn't had a wire across, we may really have struggled and the patient may have ended up with vascular surgery, but with the wire across, we could balloon, reopen, get flow as we did, and there was no problem. On the right, this is an even more horrific case where we actually managed to insert the sheath through the side of the femoral artery into the peritoneal cavity. You can see it's nowhere near the iliac artery. This patient promptly crashed and was bleeding out, but because we had that wire, we could deploy a balloon in the iliac, stabilize the situation, get surgical access, and finish the procedure. We've heard from Lars about the Manta. There are a couple of other large vessel closure devices, the PerQseal and the InSeal. There's the parallel ProGlide technique. So we're starting to see some progress in better techniques to get better outcomes in terms of closure. Paravalvular leak, again, it's about identifying high-risk cases. Really, that's severe cusp and especially LVOT calcification. Also, I think something that's often under-discussed is how is the patient going to manage with PVL? If you have a patient with a small hypertrophied ventricle, you can't leave that patient with anything more than mild PVL because they won't tolerate it. But if they've already got AR, if they've got a dilated ventricle, the patient may manage perfectly well with moderate PVL, and there are data to support that. Choose the right device to minimize the risk, and carefully size the case with CT, and think about high-risk cases, maximizing, oversizing, particularly with a self-expanding device where you're not exposing the patient to a risk of annular rupture. And finally, optimize implant depth. These are the data with Evolut Pro, and you can see that we've got fantastic outcomes with this valve, with fewer than 2% of patients acutely and none after the hospital admission having moderate PVL. And this is one of the first cases we did in Leeds with Evolut Pro, where we actually held on to the patient for a short while so we could use the Pro. You can see there are 2 bars of calcium at the level of the annulus, moderate severe cusp calcification and calcium extending in the LVOT. The annulus was 22.4 by perimeter. We used an Evolut Pro valve, and we oversized with a 29 Pro to optimize our chances of getting a good result without post-dilatation. And sure enough, you can see here pretty much 0 PVL with no post-dilatation with the Pro and some oversizing. And these data presented at TCT last year with the Evolut R from the forward registry show that if we size the valve more than 15%, that will give us a much stronger chance of having no or trivial PVL. And implant depth, if we go less than 5 millimeters, then we'll have less PVL. The same high implant, as Lars has already said, applies to minimizing the risk of AV block. Here in the red, you can see a 21% pacemaker risk with the old core valve system, compared to 13% in blue with core valve if we implant above, shallower than 6 millimeters rather than 6 millimeters or greater. And we've seen the same with Evolut system. If we get down to below 3 millimeters depth, then we will minimize the risk of AV block. What about minimizing stroke? One of the key catastrophic complications, and perhaps the thing we've made the least progress with in TAVI over the 10 years that we've been performing the procedure. This comes down really to cerebral protection. And what do you believe about the Sentinel trial? Eberhard and I debated this at TCT. Do you believe the primary endpoint, which showed no significant benefit in new MRI lesion volumes? Or do you believe these data from Sentinel showing a 63% reduction in stroke within 72 hours? I think maybe this is the most important slide from Sentinel, particularly that bottom line showing there's no risk of placing a Claret Sentinel device, almost, virtually 0 complications related to the procedure. So you are not going to do any harm with a Sentinel device. It adds very little time to the procedure. I can't see why you wouldn't offer it to your patients. If it was my relative, I'd certainly want them to have it. In conclusion, then, therefore, pre-procedural planning is really the key to avoid complications. When they do occur, it's almost always because you made a mistake in planning your strategy. Use that CT and look at all elements of the aortic valve complex and the vasculature to identify those patients at risk of specific complications and to guide strategy to avoid them, and employ all of the tools and techniques at your disposal to minimize the risk. Thanks for your attention.
Brilliant. Brilliant, Dan, as always. You're crystal clear. And would you mind talking just a few words about pacemakers? I mean, that bothers us, from day one, actually. And yesterday at the TAVI session, we saw a wide range of pacemaker percentages from, 6.5% to 50%. What do we have to do? Is there a common denominator that we should watch out for? Is this valve dependent, depth dependent, procedure dependent? Do you have any thoughts about that?
Yeah, I mean, my first thought is probably, maybe somewhat controversial, which is I'm not completely convinced having a pacemaker is that bad for the patient. In fact, there's some pretty decent evidence that it may be good for the patient to have a pacemaker in terms of reducing the risk of sudden cardiac death. We've seen that from the big Canadian registry data. However, there are some downsides, particularly about LV remodeling and LV function. And I think probably potentially the biggest issue is in our desire to, which is a good one, to fast track the procedure. It's the thing that delays the discharge of the patient and makes it hard to get the patient out of it. And if we have a narrow QRS, we take the temporary wire out at the end of the procedure, then we know that the patient is on track for early discharge, and that's good for the patient. All of the things you said impact on the risk. Device selection is probably the biggest, but we've seen pacemaker rates come down with all of the devices. If we look from core valve, the rates came down during the core valve experience as we learned to use the valve better, mainly through higher implants. And with Evolut, we've seen a step down in the pacemaker rates, so with the same kind of valve design. So I think valve design and type is probably the biggest factor. But I think we need to make sure that we keep a balance on what's most important. Pacemaker is at the bottom of that list of complications. I don't want to compromise on annular rupture risk, severe PVL risk, in order to minimize the risk of a pacemaker.
Thank you, Dan. I mean, I cannot resist. I know. DDA, 6.5%, Centera.
Yeah.
Yeah.
So I think that it only highlights the value of the stent frame design, because we are all more experienced in TAVI procedures and we all see a decrease in our pacemaker rates. And with the new platforms that we have, like the Evolut Pro, in our institution, the pacemaker rate with Evolut Pro is about 10%. So it's very low. So it has to do, as you mentioned, Dan, it has something to do with the procedure, implant high, maybe avoid predilatation, being gentle with the surrounding anatomy and identifying those real patients who really need a pacemaker, not being too liberal in the implantation of the pacemakers, because some of the patients have a pacemaker and then don't really need it. After a couple of days or weeks, they don't need the pacemaker anymore. So, but the stent frame design plays a role, and maybe there is a room for the future improvements in the various TAVI platforms that we have to make sure that we, by these technical refinements, we decrease the rate of pacemaker.
But we need to keep a balance. I mean, I think, as Lars has said, there are patients having late, sudden cardiac death, and some of those are definitely due to AV block. The data he alluded to show clearly if you send patients home with a right bundle branch block, if they have a pacemaker, they're okay. If they don't have a pacemaker, their late mortality is increased. So we've got to keep that in mind as well, I think. It's not all bad putting a pacemaker in.
Okay, thank you very much. I think we have to move on.
Yeah. Okay, so the last speaker is Flavio. Flavio is going to demonstrate the advantages of the Evolut platform, its versatility in various challenging situations to optimize the outcome.
Thank you, Didier. Thank you, everybody. This is a series of examples on how this valve platform may turn to be very helpful in some specific cases, which some of them has been already discussed during the previous talks. One is the uneven distribution of a lot of calcium in the aortic root, which enhances the risk of rupture. Then is tortuous anatomies. This is a very flexible system that can help to deal with tortuosities in the aorta or in the iliac arteries. There is an issue which is very, very common, which is the association in between coronary artery disease and the aortic stenosis, which is getting more and more interest, and how to treat this. And this specific valve has some advantages on my personal point of view. Then there is a very difficult group of patients to treat, which is the valve-in-valve cases, in especially old ladies with the valvular mismatch that had been treated surgically with very small bioprosthesis, then need a TAVI procedure, and then of course you have the risk of having a high residual gradient after the implantation of the transcatheter valve. And then I will show you some cases, of course, which should not be shown because these are off-label situations, but patients are patients, even if they are off-label, and sometimes they have very few therapeutic alternatives. And so this is the kind of cases I will show you. Severe calcification involving the coronary ostia, concomitant coronary artery disease, bicuspid valve. We had a great example this morning, small valve-in-valve and aortic pathology associated. And this is a case with a lot of calcium. And again, there is a very uneven asymmetric disposition of the calcium. This is really very high risk case for rupture in case of using a balloon expandable. And there is calcium going also to the mitral apparatus here. You see with a high implantation, thanks to the possibility of retrieving and reimplanting the valve, we got a good result. This is another case. Look at the quantity of calcium that's going to the mitral and the septum. And this is clearly shown here. It's also one single calcification involving the mitral annulus, the mitral leaflets, and the aortic valve. And again, with the valve implantation at a high level, thanks to the possibility of having a very precise implantation, you get a good result. And surprisingly, look at the reduction of the mitral regurgitation. There is an interaction in this aortic mitral junction that we are attaching. And in this case, it was amazing to see how the mitral regurgitation was reduced after the TAVI. And this is another case of a lot of calcium. Calcium is bad in general for everything in interventional cardiology. You see the calcium here is going to the coronaries. Look at not only to the mitral, but also to the ostia of the coronary, the right and the left. And this is a block of calcium at the ostium of the right coronary artery that was treated with rotablation after the valve implantation and stent. And you can see the nice angiographic result in this case, despite this quantity of calcium. Then moving to other characteristics I like of this valve, it's the possibility of implanting the valve with the minimum aggressive behavior, which is not doing pre-dilatation, not needing rapid pacing. And this is the case of a lady with a totally occluded left main. As you can see here, there is a big right coronary artery, but there is no left main open, just some collaterals. And the valve was implanted uneventfully without rapid pacing. And this is the echo follow-up after 4 years of survival with just some stable angina and no left main artery open. Bicuspid valve, I will go very briefly on this because we discussed the first case this morning, all what should be considered. This is my preferred valve for bicuspid. Of course, a high implantation will put your valve at the supraannular level, trying to have the most symmetric expansion of the leaflets. Here is a clear case of bicuspid with a very low residual gradient, and this is a CT scan after 1 year showing the good expansion and the good symmetric opening of the valve. Small valve-in-valve procedures. This is really a growing problem because the old population of patients that got a surgical prosthesis in the past sometimes were treated with this very small, I think that none of us would ever dream to implant a 19 millimeters valve in a patient, but then they come with the generation of the valve and you need to implant another valve. Well, the supraannular structure of this prosthesis, you see that the valve will be much higher than the annulus of the surgical valve. It will be working properly, and this is a case we did last year in a patient with an Evolut R23 that was discharged with a mean gradient that was below 14 millimeters of mercury. So I think this is a remarkable advantage of this valve design. What else? These are cases I should not show, I know, but my people from Medtronic, they are good with me, so they show me these cases. This is a case of a patient that had an aortic reconstruction with a TEVAR and developed aortic stenosis, so he was scheduled to undergo TAVI, but at the time of the procedure, what we found is this huge false lumen. It's a type 1 aortic dissection. And at this time, of course, we thought what to do, what not to do. In the end, we decided to perform the TAVI. You see, it's a very horizontal aorta, extremely horizontal, with a large dissection in the ascending part of the aorta. Finding the through lumen, putting 2 stiff wires, we managed to implant the core valve with an excellent hemodynamic result, and with a nice finding at the pre-discharge CT scan that the valve was actually closing the entry site of the aortic dissection at the level of the aortic root. This patient is doing well. He had undergone already 6-month echocardiographic follow-up. He's clinically doing very well, and the dissection is stable. And last, this is one of my favorite indications, is the pure native non-calcified aortic disease, which is really a big problem, especially in emergency patients developing heart failure that are very difficult to treat. This is one of the cases. We have recently published a series of 15 consecutive. You can see that there is absolutely no calcium in this aortic valve, which is quite dilated. You see the diastolic pressure in the aorta, which is mostly similar to the end diastolic pressure in the left ventricle. So it's an hemodynamic difficult situation that can be luckily solved with the implantation of a single valve if you manage to oversize the processes at least a 13-15% compared to the aortic annulus. This is a single valve implantation, perfect angiographic results, and you can see hemodynamically now there is a decent diastolic pressure of 80 millimeters of mercury. So these are, I know, specific cases. I hope you have liked this presentation, but my main message is that in the cath lab, we get always older and more complex patients. These are very different scenarios, and the core valve is the same valve in all these scenarios that can be very helpful. Of course, you have to learn how to use it in other than simple TAVI cases, and this requires the learning of some tips and tricks so that you can use it in most of your cases, but particularly in the most challenging cases you will discuss with your heart team. Thank you.
Thank you, Flavio. Excellent, excellent presentation. I can assure you we all liked it. So excellent. So why don't we just, any questions to Flavio from us or from the panel? We're going to go through this in a second. We have 7 minutes, I guess, Didier?
So I have a first question for you. You've nicely demonstrated that this platform can be used in challenging cases. If we come back to the pure aortic regurgitation presentation, what are the main tips and tricks that you use procedural-wise just to achieve a good outcome?
Well, first of all, I have to make clear that this is not a treatment for elective cases. I mean, aortic regurgitation is for surgical candidates, but aortic regurgitation causes a very silent evolution of the disease, and sometimes when patients come to the hospital, they have a very depressed LV function and the surgical risk is unacceptable. So at that point, we consider what we call emergency treatment of these non-elective cases. And technically, if you can perform the CT, this is very important because I think the most important issue when you select your valve is the oversizing. With an oversizing of above 15%, you can be confident that you will manage the case with a single valve. This is the most important thing. The second one is the tip and trick of pulling and pushing the wire and the system, because of course it's like when you do the balloon valvuloplasty, the valve will try to go either too deep in the ventricle or to jump in the aorta, so you have to exert a continuous pressure on the two things, on the wire and the valve, to have it still in a position until you reach a good result. And the third one is that in nearly, let's say, 10% of cases, you will need to implant a second valve, especially because sometimes the aortic root and the aortic annulus is so dilated that even the 34 will not be enough. So you might need to implant a first valve at the landing zone and then implanting the second one in the right position. Using this technique, we have treated 3 patients, and it's amazing to say that they have more than 4 or 5 years of survival being totally asymptomatic.
Yeah, I think I'd like to hear this, but I think we should emphasize this is off-label use.
Absolutely.
And at least it is my or our philosophy that if you decide to use a self-expanding valve, in this particular case a core valve, always be prepared to have a second valve ready. Because if the valve moves, then you better act quickly to get the second one in, otherwise, it takes too much time. The second thing that I would like to address is the pacing, which we usually don't do, at least I don't, and for aortic insufficiency, I think it makes a lot of sense.
Yes.
To pace.
Absolutely.
Yeah.
Yes, you lower the cardiac output in each beat, and it makes the deployment a little bit more stable. It depends. When you have a severely impaired LV function, it may not be needed. But if you still have some contractility, a pacing at about 100, 110 beats per minute is useful.
Yeah, and the other thing that, we always feel kind of bad if we have to implant a second valve, at least we don't like to do it. But I think in aortic insufficiency, given that we don't have a good valve designed for aortic insufficiency, I don't think we should consider this a complication. I think you might expect this to be part of the procedure. I wonder how you guys feel about that. Second valve.
Lars?
Yeah, I think it was a very good comment you came with, Flavio. But I would just say one thing about using core valve technology in aortic regurgitation. It makes sense to oversize. But my colleague Ole de Backer actually managed to gain a quite large cohort of patients who had TAVI for pure aortic regurgitation. And now I'm talking about patients who have just aortic regurgitation, no calcium in the annulus. So the landing zone is quite slippery. And he could show that if you oversize with the core valve, you actually have a higher embolization rate. And I think that's because it's tapered, and if you oversize it too much, it may slide in this slippery landing zone. So just to say, maybe not as a rule you should oversize. You may actually have a better outcome in those patients. Just stick to the sizing matrix.
Would you agree that you implant deeper instead of higher?
I don't think so. I think you should just stay. But again, it's all about to get the valve to anchor on the spot.
Yeah, but if I get that. But if it doesn't anchor, then with a little bit of a deeper, I'm not talking about deep implant.
But then you should have a patient where the LVOT is more narrow, so you use the LVOT for anchoring more than
Yeah, I mean, I think you try and deploy high. I mean, the problem with the LVOT is usually these patients have got dilated ventricles, and the LVOT is not giving you a good anchoring zone. So I think our technique is to aim to deploy high and be relaxed about a pop-up, but try to avoid the valve sliding in. I mean, I think the difficulty it can be that if the first valve slides in a long way, then you may have difficulty getting the second valve to give you a seal in terms of preventing paravalvular leak. If the first valve goes in very deep, then sometimes the second valve with the self-expanding technology can't push the waist of the first valve frame out to touch the anatomy. And I've certainly seen a few nice cases presented of deploying a balloon expanded valve as the second valve inside a self-expanding core valve as the first valve. The advantage that gives you is, the balloon expanded valve is no good for the first valve, but once you've got the frame with a deep position of the Evolut system or core valve in the old days, then the balloon expanded will actually be able to force out the frame and give you a seal. So that's another kind of option that you can keep up your sleeve.
Okay, so that was overall excellent. It's almost time to conclude. So. What did we learn today? First of all, it was, to my opinion, a very important and excellent session because we could tackle several key burning issues for our daily practice. We could see that optimizing procedural aspects of the TAVI is very important, even in extremely challenging cases like the first bicuspid that we have. Planning the procedure, understanding the patient, selecting the right platform is of paramount importance to achieve exceptional outcomes. We've had a wonderful discussion with all of you with your questions about how do we select the proper patient for early discharge, a safe early discharge regarding conduction disturbances, and even with the Evolut Pro platform, we can expect less than 10% or a 10% pacemaker. So if we select the appropriate patients, we shouldn't be afraid about early discharge, even with the self-expanding platform. We've seen outstanding clinical cases from Flavio and Dan, and so I would like to thank first Medtronic for hosting this excellent TNT. Thank you all for attending that session and being so interactive with your questions. And at last, thanking my co-chairman and the panelists. Thank you.